Welcome to the Healthcare IT Today CIO podcast. I'm John Lynn, the founder and chief editor at Healthcare IT Today, and I'm excited to bring you the most practical healthcare CIO insights and perspectives. We know your job is challenging. We want to help you be more successful. And today's guest, I think, is going to have some really interesting perspectives coming from a children's hospital, also a doctor. So we're here with Natalie Pageler. Dr. Natalie Pageler. I should be official. I was going to say MD either way. CMIO at Stanford Children's Health. Welcome, Natalie.
Thanks for having me.
Yeah, so before we dive into kind of our topic for today, tell us a little bit about yourself and Stanford Children's Health.
Yeah, sure. My pleasure. So as mentioned, I'm Natalie Pageler, the CMIO at Stanford Children's Health, as well as a practicing pediatric critical care doctor. I'm also the fellowship director for the clinical informatics program, which stretches across all of Stanford medicine.
Wow.
And you asked about Stanford Children's Health too, so let me give you a little bit of background there. So we are a tertiary children's health system in the Bay Area. We have a primary children's hospital, which has around 370 beds, and then 60 ambulatory sites spread across the Bay Area, take care of a wide range of pediatric and obstetric care here across the Bay Area.
Yeah, so I'm excited to learn more. And, today I want to kind of talk about telehealth and digital health and what you see. And I think it will be also interesting to hear how does it work at a children's hospital versus the other. But where are you really at when it comes to telehealth and digital health adoption? What have been some of your biggest successes?
Yeah, well, we've had a fairly long history of trying to implement telehealth. It started with one of our really passionate clinicians, Bill Kennedy, a urologist who was piloting telehealth programs over a decade ago. But of course, we had been ramping up telehealth prior to the COVID pandemic, and the COVID pandemic really launched our program like it did across the country and the world.
The ramp up was a little faster than you expected.
Exactly. Yeah, we flew right through our goals for the year last year. We had been doing about 3,000 visits a year. We've been climbing each year and tripling.
You were excited, right?
We were
3,000 was a lot.
and yes, of course, we are now 40x that. I think in the course of last March, we went from about 20 visits a day at the beginning of the month to over to 700 to 800 visits a day by the end of the month, and pretty much stayed there. So I would say that is definitely one of our huge successes. I think we were well positioned because we had been developing our program and our technology so robustly, and we were able to upscale. We did upgrade our technology during the pandemic because we found a lot of new issues that were coming to play as you had these huge volumes. But we also found a ton of just great successes that we weren't quite, kind of serendipitously discovered. So, for example, our developmental and behavioral pediatricians all switched to telehealth during the pandemic and quickly realized that they were actually getting more information about the children when they were seeing them in their home environment. And to the point where they say that going forward, no matter what happens with this pandemic that we are hopefully coming out of, that they will continue to do their intake visits via virtual visits because they get that much information.
Wow, that's a really interesting finding. And that was, part of what I was going to ask too. Like, do you think it will continue? It's a great example that the intake will continue at least. I mean, I think that's where we're getting right is more granular in what worked, what didn't, what was more effective, what wasn't. Is that where you're kind of at? And where do you think that's going to go adoption wise?
Yeah, absolutely. So, I think we've been really excited and fortunate to see our levels of telehealth continuing, whereas I know in some places it's really dropped, but we're continuing to see a large number of telehealth visits still staying in that 700 to 800 visits a day range, and really kind of discovering what the optimal use cases are for telehealth, which types of visits are not appropriate for telehealth, which types of visits are appropriate for telehealth or in person, and which types of visits really are just could be even better via telehealth. So really trying to sort that out going forward. Additionally, I'd say that we did roll this out very quickly across the organization. And there's lots of lessons learned and kind of lots of processes to be optimized. So Aaron Ballard, who's our current director of digital health right now, is really doing an extensive a body of work to look at the process from beginning to end and streamline that experience for patients, providers, staff. There's a lot of work to be done there.
Yeah, no, that makes sense. What's interesting is that you're right that a lot of people have fallen off. Do you think it's your patients that are kind of demanding it because of where you're at? Or do you think it's the doctor saying, no, we're fine with it, we want to keep doing this? Or is it kind of a mix of the two?
It's a great question, and we're honestly trying to figure it out. I think it is a mix. So I think, one, we are in Silicon Valley. Many of our patients and families expect this type of service and this type of technology to be in play. Two, we have very innovative physicians and staff, and they have found things like the developmental behavioral pediatricians I told you about. Similarly, another very innovative program is with our HIV pre-exposure prophylaxis program, and using telehealth to reach teens that would be otherwise hard to reach for that. So some real innovation to find the right use cases. And then, I think we had done a lot of work here to build out our platform and our processes prior to the pandemic. So it really is kind of a robust support model, and in many cases, people are finding the experience as good in telehealth, if not better, than in person. So I think that helps support the continued use of it.
That makes sense. I imagine a lot of hospitals rolled it out in a less than optimized manner, and of course the doctors hated it, and so then they didn't want to keep doing it. That makes sense.
Exactly. Yeah.
That's a great example. So what's next on the radar to implement? I mean, I think live video telehealth visits made sense. We had to do it, right? I mean, COVID forced our hand. What else are you looking at from telehealth or even digital health perspective?
Yeah, so I think there's a wide range of initiatives. One is that process optimization that I talked about, and that's going to be critical work to continue to optimize the experience for patients, staff, and providers. Two is we're doing a really in-depth look at digital at equity. I think one of the advantages of digital health is that it can reach patients who may have been harder to reach, but it may also exacerbate the digital divide. And so Lisa Chamberlain, one of our incredible advocacy leaders, has been helping to lead an entire group to delve into the data and looking at who might be left behind in this digital transition, and trying to figure out how can we help reach some of those patient populations who are unable to access digital health in the same ways as our other populations. So that's a piece of it. And then, also just continuing with this work, I think, we all want to take healthcare to where the patient is and where they need it. And in pediatrics in particular, that can be incredibly important because pediatric specialists are few and far between. So it's not uncommon for our patients to have to travel 3 or 4 hours for a 15-minute follow-up visit. And so I think in pediatrics in particular, trying to lessen the disruption on the child and the family's life is a major goal for us. And, we know that when a patient has to come for a full day, spend a full day coming for a visit, they miss school, they miss their extracurricular activities, their parents miss a full day of work. It's a major imposition on the family. Yes. So we're really continuing to try to take healthcare that was inpatient that can be moved ambulatory, healthcare that was ambulatory that can be moved to home, and trying to switch to this more continuous supportive mode of healthcare delivery from the historical reactive intermittent healthcare delivery. And that includes things like thinking about home monitoring, thinking about, more virtual visits, more asynchronous virtual visits, asynchronous virtual consults, all this entire package to try to, again, to move healthcare to the patient when and where they need it.
It's so easy to say that stuff on a podcast, but it's so much harder to actually do, right? Like, absolutely. Whether it's culture, whether it's, it's not even the technology. Usually it's the culture, it's the everything. Business, it's everything else. But it's great that you're working on it because it's so important.
Yeah, and especially in pediatrics, I think there's a whole nother layer of challenges that we have to work through that, it really is kind of when you start trying to implement any of these pieces, it's where the rubber meets the road. So for example, we've been doing a lot of work trying to implement home monitoring in pediatrics. There are a few good examples in peds where manual home monitoring programs have been done very successfully. So single ventricle, a very complex heart disease, has traditionally had a very manual home monitoring program that significantly decreased the mortality rate for that population. But it literally required a nurse practitioner calling the family every day and saying, okay, look in your notebook and tell me what Monday's weight was and what Monday's oxygen saturation was, and now Tuesdays. And so, very error prone, very time intensive. And so looking to take that type of program and make it virtual, decrease the errors, make it easier, more efficient, more current. But when you start looking at peds, babies don't carry iPhones. So
they don't? I thought they were coming out of the womb with an iPhone these days.
Soon. I wouldn't be surprised, right?
If it's going to happen anywhere, it's going to happen at Stanford. That's for sure.
Exactly. Every baby comes with their own iPhone.
It's going to have their own chip implanted. And yeah, that's a different world. One day, no, actually, I hope we never get there. But anyway.
Exactly. But that presents a real problem when you talk about, giving patients access to their data and using, their mobile devices to monitor or connect to monitoring devices. We have to do everything in a unique way. And there aren't pediatric devices that are Bluetooth enabled in the same way they have in the adult world. Babies and young children usually don't have their own mobile devices, and then you're working through a proxy. You're using the parent's device, and you have to be able to sort the data, separate the baby's data that's going through mom's or dad's device from the mom or dad's data, and so it gets really complicated. And then you add on the adolescent use case, where adolescents are at this very unique stage of going from completely dependent on their parents to a hopeful autonomy, and in California, they have some very robust state laws around what adolescents should have privacy around. And so trying to separate all of that data and create, that proxy workflow and make sure the adolescents have privacy where they need it gets very complicated.
I can't believe the 2-year-old didn't do their daily blood pressure check.
Exactly.
The text message reminder didn't work to get them to do it. I mean, I was going to give them a gold star for compliance for a 10-day streak, right? It's so fascinating to think about from a kid's perspective.
Right? A whole new world.
Yeah, is that the big challenge? I mean, is some of these technology / caregiver related things, or are there other things that are holding back what you really want to implement, or maybe that you'd really like to, but it's not there? Or is it other things like reimbursement, or even just time, or even willingness at your organization? Like, what are those things that you're like, if I could solve this, I could push this forward much quicker?
Yeah, it's all of those. I think maybe not the willingness piece. We definitely have very innovative faculty and staff who really want to push care forward, and we have a patient population for the most part that is very willing to experiment and try new things with us. But so definitely thinking pediatric device, any pediatric device development is a major issue, and there are lots of different organizations, including our innovation team here, looking at how to sponsor better pediatric device development. The proxy workflow and the adolescent confidentiality pieces are incredibly challenging. We've been really trying to help lead the discussions across the nation with the AAP, with Children's Hospitals Associations, about how best to handle adolescent data privacy. But that's a huge body of work that's ongoing, especially in light of the 21st Century Cures Act. And then reimbursement models. Pediatrics has much different reimbursement models than the adult space. We are much more dependent on Medicaid than Medicare. And there's a lot more kind of still fee-for-service models and not so much of the at-risk models, which sometimes get a little bit more difficult to experiment in. It's, I think there's pluses and minuses of all the different models, but everything is a little bit different in pediatrics, which adds a whole nother layer.
So are we seeing the same digital health technologies with the adolescent populations as the older populations? Blood pressure cuff, O2 meters, right? Like, scales, or are there other ones that are pretty unique to the adolescent population? And how does that adoption curve differ?
Yeah. So, I think in adolescence for devices, I think it depends on how big the adolescent is and whether or not they can use the adult device. But again, I think it gets to be kind of the adolescent proxy workflow, the adolescent parent workflows.
And is it because the devices aren't big enough too, or is it because in the FDA clearance, they're like, we're not touching kids, kind of like they did with the vaccinations, right? Like, is that the challenge?
Yeah, it depends. So I think for devices, I think if it fits and it works, then then you're okay. I think that gets to be a much bigger problem in the smaller population. So so for the babies and children, that's where we really run into device issues. But for teens, like there's a lot of people, you start dealing with COPPA, the Children's Online Privacy Protection Act, and like what types of how do we keep teen data private? How do teens have their own mobile device? Do their parents know that they have their own account? Are they allowed to have their own account? Does the teen, I think adolescent compliance is a huge issue. And so if you're going to try to set up a home monitoring program and you're going to try to have the adolescent be in charge of it, are they keeping their device with them? Are they keeping it up to date? We've got a really robust diabetes digital health program, and a lot of our adolescents are using that, but we're constantly running into issues where they've disconnected from their glucose home monitoring program, or something's not working with their phone, or they lost it, and then suddenly we lose that feed. So it's just kind of adding all the complexities of being a teen onto this already complex digital workflow.
Yeah, that makes sense. And from a compliance perspective, that's interesting, right? It's just so many different things that we don't think about as adults that should be pretty responsible. Yeah. Underline the should, I guess, but there's a lot of adults that act like kids too. So maybe we can learn from you.
Right. Once we figure it out, we'll share it with the rest of the world.
I'm talking about myself mostly. But well, let's shift gears a little from kind of digital health, but kind of a CMIO. What's the key to leading a successful project? What's some learnings, for other CMIOs, CIOs that are out there listening?
Yeah. So, I think everything is people. And so I think, at your very, very local level, making sure that you've got great relationships with your IS or IT team. I am actually, there's so many different reporting structures. So I report to our CIO. I'm an part of our just amazing IS leadership team, and very integrated within our department. I run a portion of the department, run the EPIC training or EHR training team, and our clinical informatics team within that department. So I'm very tightly integrated, which helps tremendously for moving any informatics work forward. And then the partnership across the organization. So if you're trying to implement a project successfully, that operational and clinical ownership is absolutely critical. And of course, I'm spanning the world between the IS and the clinical teams, but I have my own small sphere of experience, and it's really important to make sure that I'm partnering with the right operational and clinical leaders for any major project. So I think that's key. And then, I'm Stanford Children's as part of Stanford Medicine. So also having the right relationships across Stanford Medicine. We just rolled out the 21st Century Cures Act like everybody else in the nation. And we had a really tight knit team with our compliance team and the CMIOs at both hospitals or both healthcare systems and the operational leaders. And I think that collaboration was what helped us move that forward in a very effective way. And then taking it to the even bigger sphere, right, is the networks across the state, across the region, across the nation. And that's been incredibly helpful, especially in pediatrics. So again, kind of referring to the 21st Century Cures rollout, we formed a pediatric informatics group across the state of California. Cindy Kelbs down at Rady and I helped lead that. But it was incredibly helpful to get all of these informatics leaders across the state together to say, hey, we're all implementing the 21st Century Cures Act. We're all in California with these very strict California state adolescent privacy laws. How are you all navigating it? How can we learn from each other? How can we create an approach going forward? And similarly, having those conversations again with my friends, across the nation, with the AAP, with the Children's Hospital Association, I think really helps inform the right approach. And I think that's, again, especially important in pediatrics, where the children's hospitals are kind of few and far between.
Yeah, I imagine there's a nice bond. I've seen it a few times with children's organizations. It's like, oh wait, we can talk. It's like you have your own language, right?
Exactly. Yeah, it's an amazing atmosphere, both within the hospital and then across children's hospitals, where everybody's in this work to make children's lives and families' lives better. So there's a lot of sharing and collaboration that goes on. I think more so in this space than maybe some other spaces.
Yeah, that's fair. What career advice would you give to someone who, would like to be a CMIO like you? I think we can talk about the elephant in the room. There's not enough female CMIOs either, right? So, what's some career advice you'd give to someone who wants to be the next Dr. Pageler CMIO?
Yeah, I think there's so many different ways to approach this role, and I think there are more and more formal ways. So depending on where they are in their career, I would give them very different advice. I think for a young resident or a clinician who's just thinking about this, we do now have formal clinical informatics training programs, and the fellowships are incredibly innovative and provide incredible experience across the hospital. So really thinking about that type of formal training versus several of the professional organizations have CMIO boot camps and things like that. I think it's a great way to connect with your peers and learn some of the formal training. I think diving in, so finding a project that you can really engage in and really truly experience what does it mean to do informatics is incredibly helpful. And then just connecting with people. So, whether it's somebody who's doing the role, reach out and talk to them. I'm always happy to talk to other people who are thinking about this career. But then also those bigger networks that I talked about. So join the professional organizations across the nation, find your peers who are struggling with the same issues you are, and start creating those collaborative networks. And I think that's what really helps us all kind of rise together. And I've definitely navigated my way through this career with the help of a wide range of people who have supported me and taught me and guided me. Chris Longhurst was the CMIO before me, who introduced me and taught me a huge amount. And then, all of my colleagues across the nation. So I think those connections are just invaluable. And that's really what helps you be successful in this career.
Excellent. Great advice. And thanks so much for taking time to join us here on the Healthcare IT Today CIO podcast. And thanks everyone for watching. If you want to find more great healthcare IT content like this and check out the rest of the series of the CIO podcast, you can find it at healthcareittoday.com. Thanks, Dr. Pageler.
Thanks, John.